Welcome back to the Deep Dive. Today we're digging into a topic that honestly surprised me, pediatric dental care. Seems the whole approach has shifted.
It really has. Forget waiting for a problem. Modern pediatric dentistry is all about getting ahead of issues, focusing intensely on prevention, especially over the last, say, 20 years.
Right, moving away from just reacting to emergencies.
Exactly. So our mission today is to really unpack what goes into that first crucial non-emergency dental visit for a child. We're talking goals, psychology, the whole plan, based on some really comprehensive sources.
Okay, and those sources lay out 5 key goals for that visit, right? It needs to be systematic.
That's right. 5 pillars, you could call them. History taking, a thorough examination, getting the diagnosis right, creating a treatment plan, and then some kind of introductory treatment. It all flows together.
Let's jump right to the timing then, because that's maybe the biggest misconception people have.
Absolutely. So many parents think, oh, age 3 is fine. But the actual recommendation now, no later than the child's first birthday. Unless, of course, there's a specific problem even earlier.
The first birthday, wow. That still feels really early to a lot of folks.
Yeah.
What's the concrete benefit?
Well, first you get a baseline. You can monitor how the jaw and teeth are developing from the get-go. But honestly, the main thing is guiding the parents.
Guiding them on what specifically?
On proper oral hygiene for an infant, explaining preventive steps like fluoride, talking about diet, which becomes huge as they start solids, and, importantly, advising on habits like pacifiers or thumb sucking before they potentially cause bite problems.
Okay, so you get the appointment booked, it's a checkup, not an emergency. Then the actual environment of the clinic becomes paramount.
Oh, it's massively important. That first impression can literally shape the child's attitude towards dental care for life. So you need things like a dedicated kids area, maybe some children's music playing.
And minimizing the scary stuff.
Yeah, definitely. Trying to mask strong smells, and crucially, dealing with the sounds. That high-pitched whine of the drill. We use something called audio analgesia.
Audio analgesia.
Yeah, basically using other sounds like music or even white noise to cover up those anxiety-inducing equipment sounds. It makes a big difference.
And the team interacting with the child.
Just as critical. Staff need to be trained, cheerful greetings, talking about things the kid actually likes, cartoons or pets, not just teeth, and using simpler language if needed, sort of kiddie talk.
But the biggest influence starts before they even walk in the door, right? The parents.
Absolutely. Parental attitude is key. It must be positive. And the number one rule, never, ever use the dentist as a threat for bad behavior. That creates what we call subjective fear, and it's incredibly hard to undo.
Okay, subjective fear. We'll circle back to that. Let's move into the actual appointment, the history and examination. This isn't just paperwork.
Not at all. It's where you build rapport. It's also where you can pick up signs of general health issues, not just dental ones.
When you're taking the history from a parent, especially for a really young child, what are the pitfalls?
Well, 2 main things. 1, the information might be incomplete or maybe slightly skewed by the parent's perception. 2, the child can feel ignored if you only talk to the parent. It needs to feel like a relaxed chat, not, an interrogation.
What kind of details are you digging for in that history? What stands out?
The depth of the medical history is pretty significant. We obviously cover current issues, childhood illnesses, meds, but we go way back sometimes to the neonatal period.
Neonatal, like right after birth.
Exactly. Things like birth weight, birth length, any delivery complications, even if the baby had significant jaundice, icterus.
Why does something like jaundice matter for their teeth later on?
Because events happening around birth during that perinatal time can actually affect how the permanent teeth develop and calcify, potentially making them more vulnerable down the road. It connects the dots.
That really underscores the importance of that early first birthday visit then.
It does. And we also cover the social history, basics like name, age, but also school, siblings, parents' jobs.
Parents' jobs. How does that influence dental care?
It helps assess the family's background, maybe their expectations, and importantly, it ties into the adaptability of the treatment plan. We need to offer options that are realistic for the family.
Realistic. You mean affordable. That sounds tricky.
It's about making the plan work long-term. Say a child needs crowns. We have durable, cost-effective options like stainless steel crowns, or we have beautiful but much pricier zirconia crowns. The A for affordable and adaptable in our planning principles means choosing what the family can actually follow through on, ensuring the child gets the necessary care completed. It's not about cutting corners on quality, but matching the solution to the situation.
That's a really practical way to think about affordable What about the dental history part?
That covers any previous dental visits, how the child reacted, any oral habits we haven't discussed, fluoride exposure, and crucially, the chief complaint. You have to ask both the parent and the child, if they're old enough, why they're there. Their answers can be surprisingly different.
Okay, history done. Now the clinical exam. And it might not even be in the traditional dental chair.
Right. For infants, toddlers, or kids with special healthcare needs, we often use the knee-to-knee position. The parent sits facing the dentist, knees touching, and the child lies across their laps. It feels more secure for the child and gives good access. Or, sometimes we examine the child right in their wheelchair if needed.
When you're just observing the child as they come in the general appraisal, what are you looking for?
Little clues. Their stature, height, and weight compared to growth charts. Their gait, is it steady? An unsteady walk could suggest illness or a motor issue. Their speech patterns, even their hands, any skin lesions. Signs of thumb sucking. It gives you instant information.
Then the head and neck exam.
Yeah, looking at head size and shape checking for things like microcephaly or macrocephaly. Skin, hair, signs of conditions like ectodermal dysplasia, any facial swelling or asymmetry. We check the TMJ, the jaw joint, though actual pain is rare in young kids. Clicking or signs of bruxism, teeth grinding are common, and palpating lymph nodes in the neck for swelling, which could indicate infection.
And then inside the mouth, the sources really emphasize looking at soft tissues before the teeth. Why?
Because the soft tissues, gums, tongue, cheeks, palate, can show signs of systemic diseases. Think Koplik spots, which are an early sign of measles, or an unusually large tongue, macroglossia, sometimes seen with Down syndrome, or even a short lingual frenum, a tongue tie. You spot these potential health flags first.
Before zooming in on cavities.
Exactly. Then we get to the teeth, the hard tissues. Check the number present, their size, color, any stains. For detecting caries, cavities, you absolutely need a clean, dry tooth surface, good light, a mirror, and often bite-wing radiographs to see between the teeth.
What makes a tooth surface particularly susceptible?
Several things. Deep pits and fissures, especially on molars. Crowded teeth are harder to clean. Developmental defects like enamel hypoplasia, where the enamel didn't form properly. And also, how long the tooth has been in the mouth. Newly erupted teeth are less mineralized, kind of immature, and more vulnerable to decay.
The level of detail is incredible.
Yeah.
Now, let's talk behavior. This is often the biggest hurdle. The source is called pediatric dentistry, a two-way relationship.
It really is. You're treating the child, obviously, but you're also constantly managing the parent or guardian who's right there, influencing the situation. Understanding the child's developmental stage is key to anticipating their behavior.
Right, the psychographic profile. Let's start with the 2-year-old.
The trability stage, we sometimes call it. They're super attached to the parent, often have significant stranger anxiety. You should expect crying, maybe screaming, very little verbal communication. The goal is mostly just gentle introduction.
Then they hit 3.
The semi-infant or Me Too stage, they're starting to want independence, and they love to imitate. This is perfect for using a technique called modeling.
Modeling.
Yeah, having them watch another cooperative child, maybe an older sibling, get treatment successfully. They see it's okay, and they want to do it too. Me too.
And age 4.
That's the why stage, sometimes called HAB and wising. Suddenly, they're full of questions. Why are you doing that? What's that tool for? This age is ideal for the classic tell, show, do technique.
Tell, show, do. Explain that.
Simple but effective. You tell them what you're going to do in simple terms. You show them the instrument, maybe let them touch it or feel the air water spray on their finger. Then you do the procedure exactly as you described. It removes the fear of the unknown.
Let's tackle fear itself. We know objective fear comes from real things. Pain, loud noises, the sight of blood. But you mentioned subjective fear earlier as the toughest. Why?
Because subjective fear isn't based on the child's own negative experience. It's based on stories they've heard from friends, siblings, maybe even things parents have said without thinking, or stuff they see in cartoons or media. It's fear built on imagination or suggestion.
And that's harder to deal with.
Much harder. You can address an objective fear, use audio analgesia for noise, be gentle to minimize pain, but countering a narrative that's already planted in their imagination, that takes consistent effort, building trust, using those behavioral techniques repeatedly.
And sometimes parenting styles contribute to the problem.
Oh, definitely. Extreme styles can make cooperation difficult. Overly affectionate or indulgent parents might lead to a child who expects constant control. Overprotective parents create kids who can't tolerate any discomfort. Overly critical or authoritarian parents, that can lead to defiance. And rejected or under-affectionate children might act out for attention. The dentist has to read these dynamics too.
So how do you actually classify or rate a child's behavior in the chair? I know there are scales.
There are. The simplest and most widely used is probably the Frankel scale. It's a quick snapshot.
How does Frankel work?
It's a 4-point scale. Definitely negative, they're refusing treatment, crying forcefully. Negative, they're reluctant, maybe whining, but follow directions. Positive, they accept treatment, but might be a bit wary or reserved. And definitely positive, good rapport, interested, enjoying the situation.
Okay, that gives you a level. But what about why they're behaving that way?
Right. For understanding the reason behind non-cooperation, other systems are helpful, like the HELPed classification, which looks more at the type of behavior like uncontrolled crying versus manageable crying, or tense versus cooperative, or the SHY classification.
Shy classification, what does that focus on?
It tries to label the source of the resistance. Is the child genuinely shy, or are they fearful, are they hyperactive, or are they just being resistant or obstinate, maybe emotionally immature for their age? The key concept here is identifying the potentially cooperative child.
The potentially cooperative child.
Yeah, that's the child who could cooperate, but isn't right now because of one of those factors, fear, shyness, etc. They are the primary target for our behavior modification techniques. If we understand why they're resistant, we can tailor our approach.
Makes sense. One big question related to parents: separation. When is it okay, or even necessary, to ask the parent to leave the treatment room?
It's a delicate issue. Separation is generally contraindicated, meaning not advised for the very first visit for any child under 2 years old and for children with special health care needs. You need the parent there for support and familiarity in those cases.
But sometimes it's needed.
Yes, separation might be necessary if the parent is extremely anxious themselves and that anxiety is clearly transferring to the child, or if the parent is constantly interrupting, correcting, or hovering in a way that distracts the child and undermines the dentist's rapport building.
And if the parent does stay?
The ideal position is often standing quietly behind the dental chair, sort of out of the child's direct line of sight. This allows them to be present, but prevents the child from constantly looking to them for cues or rescue.
Okay, behavior managed. We're nearing the end goal. Next is diagnosis.
Right. Diagnosis is basically pulling everything together, the history, the clinical exam findings, the assessment of their behavior, and it leads to one really crucial determination, which is the patient's caries risk status. Are they at high, moderate, or low risk for developing future cavities? This assessment drives the entire preventative and recall strategy.
And based on that diagnosis and risk level, the treatment plan.
Exactly. And this plan isn't just a list of procedures. It's defined as a well-thought-out sequence. It has to follow those principles we touched on: simple, affordable, and adaptable, the SAA principles.
Simple, affordable, adaptable. Got it. And it's structured in phases.
4 distinct phases, typically. Phase 1 is the emergency phase.
Dealing with immediate problems.
Yep. Relieve pain. Manage any acute infection or trauma. The key here is often being conservative initially, maybe just enough to get them comfortable, delaying more complex things like extractions if possible. And this phase critically includes caries control.
Caries control. What does that mean in practice during an emergency visit?
It means actively trying to stop existing cavities from getting worse quickly, even before we get to the main restorative work, which might be weeks away. This could involve excavating just the soft, mushy part of a large cavity, or applying something like silver diamine fluoride, or SDF.
SDF.
Yeah, it's a liquid we can paint onto cavities, especially in primary teeth. It chemically arrests or stops the decay process. It does stain the cavity black, but it's a very effective, non-invasive way to control caries quickly.
Okay, phase 1 done. What's phase 2?
The preventive phase. This is really preparatory work. It includes professional cleaning, oral prophylaxis, applying topical fluoride, placing pit and fissure sealants on susceptible teeth, providing diet counseling, and reinforcing patient-parent education. We also identify any developing bite issues or crowding here.
Phase 3 is when the fixing happens.
That's the restorative phase or corrective phase. This is where we do fillings, amalgam or composite, place crowns like stainless steel crowns, SSCs if needed, perform pulp treatments like pulpotomies if decay reaches the nerve, and handle any necessary extractions. And if a primary tooth is lost early, placing a space maintainer is crucial in this phase.
And the final phase keeps everything on track.
Phase 4, recall and maintenance. This is vital. We need to regularly evaluate how effective our preventative advice and restorative work have been. Children generally need recalls more frequently than adults.
Why more frequently?
Because decay can progress much faster in primary teeth. Their enamel is thinner. So a high-risk child might need to be seen every 3 to 6 months. A low-risk older child might stretch to 12 months, but regular checks are key.
When actually planning the sequence of treatment within, say, the restorative phase, what guides the decisions? You mentioned urgency, sequence, and prognosis. Let's talk sequence.
Okay, sequence. We generally aim for quadrant dentistry, treating one whole section of the mouth at a time for efficiency. But there's a specific order preference, especially after age 6.
Which is?
We usually prefer to treat the maxillary arch, the upper jaw, before the mandibular arch, the lower jaw, once the child is around 6 or older.
Why that specific upper before lower order after age 6?
It comes down to anesthesia, mainly. Around age 6, the permanent first molars erupt. To get the lower molars numb effectively, you often need mandibular block anesthesia. That's a deeper injection that numbs a larger area, half the jaw, tongue, lip. It can feel strange and be a bit more intimidating for a child.
And the upper jaw.
The upper teeth can usually be numbed with infiltration anesthesia, which involves smaller, localized injections right near the specific teeth being treated. It's generally less profound, wears off quicker, and feels less invasive to the child.
Ah, I see. So starting with the less intimidating upper jaw helps maintain their cooperation before tackling the potentially more challenging lower block injection.
Precisely. You build confidence with the easier part first. You don't want to jeopardize that trust and cooperation you've worked so hard to establish by starting with the most difficult injection. It's a very practical, patient-centered consideration.
That makes perfect sense. So looking back, it's this incredibly detailed process, starting potentially at age 1, managing the environment, digging deep into history for links like neonatal health, understanding child psychology from trability to the Y stage, classifying fear, and then executing this carefully phased SAA treatment plan.
It is, and the ultimate goal of that whole plan, all those phases, is to get the child to a point where, as the sources say, disease is controlled and the dentition is functional, stable, and of acceptable aesthetic. That's the finish line for that cycle of care.
A really thorough deep dive today. Before we wrap, here's something to chew on. We talked about subjective fear, that imagination-driven fear from stories being the hardest type to manage. Thinking ahead, how might emerging tools, maybe like positive social media campaigns tailored for kids, or even interactive mobile apps using friendly characters, be used to proactively reshape those narratives before a child ever sets foot in a dental office? Could we counter the negative stories before they even take root?
That's a fascinating thought for how we might leverage technology for prevention in the future. Definitely something to consider. Thanks for joining us on this deep dive.